morning, Chair. We're now live.
Thank you, Tom. Good morning and welcome to this meeting of the Adult Care and Public Health Scrutiny Committee. I am Councillor Jimmy Brooks, the Chairman of the committee, and sitting to my right is Vice Chairman Maggie Cullen. Before we begin, there is a standard announcement. We are not expecting a fire alarm, so if you do hear a fire alarm, please leave at the front of the building and go to the car park. In addition to welcoming all our members to the committee, I would also like to welcome Maria Hume, Executive Support Officer for Adult Care and Public Health. Other participants, we've got Martin Samuels, Executive Director of Adult Care and Community Wellbeing. Other participants will be introduced as we come to that item. Thank you. This meeting is being streamed via the County Council's website, and all comments will remain accessible online after the meeting. With this in mind, I would like to remind members to make sure your phone is turned off or on silent if possible, please. I'd also like to welcome all the members of the public and the press watching. Just a couple of housekeeping rules as well. Please turn your laptops to silent as well. Requests to speak will be collated at the top table. If you wish to speak, you can raise your hand and we will make a note, either myself or Councillor Hume. Thank you very much. Agenda item 1, apologies for absence and replacement members. Thomas?
Thank you, Chairman. We have apologies from Councillors Litchfield, Redfern and Clegg from the Executive. We also have Councillor Bailey Robinson replacing Councillor Litchfield for this meeting only, and we have Councillor Bean replacing Councillor King until further notice.
Thank you. Agenda item 2, declarations of members' interest. Members of the committee are reminded that they only need to declare any relevant interests which have not been declared on their declaration of pecuniary interest form. Do any members wish to declare an interest? No. Thank you very much. Agenda item 3. Minutes of the previous meeting of 4th of June. To confirm as correct, record the minutes of the meeting of 4th of June 2025. The minutes are found on pages 5 to 8 of the agenda pack. Have you all had a chance to read those? Could I have a proposer, please? Thank you, Councillor Robinson. And do we have a seconder? Thank you very much. All those in favour? Thank you very much. Any abstentions? Any against? Thank you. I confirm the minutes have been approved. Agenda item 4, announcements, updates. This is the standard item on all scrutiny committees, enabling announcements to be made. As the Chairman, I have no announcements at this time. Councillor Hume, do you have any announcements at all, please?
No updates at this point. Thank you, Mr. Chairman.
Thank you very much. Can I ask the Executive Director, Martin Samuels, if he has any announcements?
Thank you, Chair. Yes, there are 2 announcements I'd like to make. The first is to bring to the committee's attention that we have a new member of my senior team started on Monday of this week. Hayley Eccles has taken up the new role of Deputy DAS, Deputy Director of Adult Social Services. She will lead as part of our reorganisation. We've created a new division within the Directorate which brings together all of the social work functions across adult care, adult social care, and she is now leading that division. Hayley is an experienced assistant director, joins us from Oldham Council, where she worked for some years. She's played a really important role in a number of the schemes and developments across Greater Manchester, and members will may be aware that Greater Manchester has a very good reputation in terms of its joint working and its thinking in terms of adult social care. And she is also one of the national co-leads for the Association of Directors of Adult Social Services, so our professional association, in terms of carers. So I think she's a very strong addition to the team. Delighted to welcome her to Lincolnshire, and I'm sure she will be looking forward to being here in person for for future meetings and meeting members of the committee. So that was the first announcement. Second announcement, I think I mentioned at the last meeting that it looked like the CQC were going to be undertaking their first proper assessment of the council later this year. It has now been confirmed that the pilot assessment that was done 2 years ago was just a pilot and is considered by the CQC, the Care Quality Commission, as our regulator, to have no formal standing. And indeed, when I looked on their website a few days ago, I couldn't find it. I think they've removed it and that report and the report for the other 4 pilots. And so we've been told that they will be doing a full inspection of us and the other 4 pilots in the autumn of this year. We will be the very last in the country to be done. So I'm expecting then to get a formal notification from the CQC on the 1st of September. It is a 6-month process, whereas with Ofsted, when they do a review of children's services, I think from the point that the date of the phone call to the point where they leave with having done their site inspection and provided a confidential provisional rating is 3 weeks. We won't, the site visit probably won't happen until November, December. We probably won't get any indication as to what the outcome is until quite possibly February, and the report is likely to be published in March of next year. So it is a very different, very long drawn out process, but as we get further details, I will share that with the committee, but that will become a major focus of our work over the period. But at least we now are 99% certain that it'll be on the 1st of September that I get the call, rather than on the, I think it's the 4th of August is the date that the remaining other authorities that haven't been inspected yet will get their call. Thank you, Chair.
Thank you, Martin. The announcements are noted. Thank you. Agenda item 5. Sorry, I've got my wrong glasses on. I do apologise. Councillor Lee.
Thanks. It was just a quick question, Martin. Did you say that that's just an assessment of children's services, or is it right across different service areas? Just for information.
So my apologies, I wasn't clear. No, that is the CQC inspection will be an inspection of the council's adult social care commissioning functions. So for many years, operational functions, so the delivery of personal care, has been inspected by the CQC. So every care home in the country, every home care provider in the country is inspected by the CQC. Since about 2010, the commissioning functions of councils in terms of adult social care and their social work functions have not been inspected. This is now the first round of that process. So it is our the core functions for adult social care for the council.
Thank you, Councillor Lee. Thank you, Martin. Is there any more questions? No, thank you. Announcements are noted. Thank you very much. Agenda item 5. Adult Social Care Strategy 2025-2028. This item can be found on pages 9 to 103 of the agenda pack. This is what we refer to as a pre-decision scrutiny item, where we are looking at proposed decisions and recording our views. In this case, the decision is due to be taken to the Executive on the 2nd of September 2025. This item will be presented by Martin Samuels, Executive Director. I am aware that this is a draft document, so it is like a living document. So, Martin, thank you.
Thank you, Chair. So there's a slide deck to support the strategy. It starts on page 53 of your the meeting pack. You'll note there are something like 30 odd slides. I can reassure you I am not intending to go through them all in detail. The slide deck is really intended just as a more accessible way into the strategy. So I'll just sort of run through some of the headlines, and I'll pick up some of the slides, and where I pick up an individual slide, I'll tell you what page number it's on. So and we'll try to sort of keep up and make sure that we're right on this. So really to give an introduction, if we go to the next slide, the introduction. So what we're trying to do here is to provide a 3-year strategy setting out the vision, commitments, priorities and strategic goals of transforming adult social care services for working age adults and older people. To unpack that a bit, Lincolnshire hasn't had an adult social care strategy for some years, and I think that it has become clear that we have been feeling the want of that. So the purpose of the strategy is really to set out clearly and in a single place what it is that adult social care is about, and what it is that it's trying to achieve for the people of Lincolnshire, both so that the people of Lincolnshire can have a clear sense of what the offer and the engagement is that they can expect when they engage with us, but equally that staff within the council can be clear about the expectations and the ways of working, and indeed that the providers that we work with can be equally clear about how we work. And it's really about setting the ambition, setting the tone by which we do adult social care. And I think, as I say, we've been feeling the want of it, and one of the reasons I say that is that members of the committee will be aware I've now been in Lincolnshire for just under 2 years, and what's become quite apparent as I've been digging into the service that I inherited is that we have quite a lot of variation between different parts of the service, and that to a degree, the type of service, the type of experience and the decisions about care that a Lincolnshire person will experience and will receive are too much driven by which team they happen to connect with, rather than being driven by the needs of that individual. So the NHS has a tendency to talk about unwarranted variation. We have to be very careful in an adult social care context because of using that term, because if you're doing hip operations, pretty much you want to do every hip operation in the same way, and yes, each patient will be a little bit different, but essentially there is a best way to do a hip operation and a range of less good ways to do it, and therefore unwarranted variation is a key issue in the NHS. In adult social care, because we are dealing with people's lives rather than their medical conditions, we start from the principle that every individual is different and every individual is unique, and therefore a strength-based, person-centred adult social care system should be very commonly having variation, because it should be varying to meet the needs of the individual. But I think what we're finding in the absence of this strategy is that we are too often varying because of the service rather than because of the individual. And so the aim of the strategy is to provide that core reference to guide the services, to guide providers, to guide members of the public, so that they can really have that consistent view of the way that we should be working. And I think that's sort of brought out in the second block of text on that slide, about creating an environment that empowers people in Lincolnshire to lead, to thrive and lead healthier, more independent, self-reliant and confident lives within the resources that we have. Sorry, Councillor Overton.
Councillor Overton, would it be possible to wait until after the presentation, or is it urgent that you jump in now?
It was just for clarification,
Yes,
really.
that's
I
fine.
didn't quite understand. Yeah, so it was saying about it being, and I know you're putting your words carefully, quite rightly so, but it's quite very person-centred and varying because the service, not the individual. Do you mean the staff availability? Are some areas short-staffed? Is that the problem? Thanks.
No, the issue will be that my social care professional staff may be working with people differently, so that we haven't got a consistent way of working with people. So it's not an issue that we can't get this service, we can't get that service. Or it's the way in which we are working with people. So hopefully that
Thank you.
clarifies.
Councillor Lung, is this for...
It's on the same vein.
Fine, thank you.
Martin, in terms of transition as well, does it differ in terms of when a person or a young person is coming out of, say, children's services into adult or adult going into older people's? Does it differ? Do you find the service differs then?
So the short answer is yes. What we are finding is that if a young person is and I prefer not to talk about transitioning, but it's more about young people moving into adulthood, and that what we're finding is that if a young person has a physical disability and therefore engages with the physical disability team, they may be assessed and treated in one way, and if they have a learning disability, then they may be assessed and treated in a different way, and if they have a mental health issue, they may be assessed and treated in a different way. And of course, to some extent, because conditions are different and people are different, then there needs to be some variation, but too much of the variation is because the different teams have different cultures and different approaches, rather than because it is based on the individual and their needs.
Thank you.
Chair-
Councillor Lee, this
Yes.
is the last question we have
This is what I
until
was
after
going
the
to say.
thing.
Can we let Martin finish? Normally
Yes,
on this committee,
thank
that's what
you.
we do. I'm finding it really disruptive to
Yeah,
have bites
absolutely.
of things. We
Thank
can
you.
write questions down and ask them at the end.
Perfect, Councillor Lee, thank you. Martin, please continue.
I will try to be brief, and as I say, I won't go through through all of the slides in detail. So the next slide, those are the council's vision and values, and it's really important that we base our work on those council-wide approaches. If we then move to the next slide, just to set out briefly the aims. So we're looking to promote good health and well-being by tackling health inequalities and improving access. So health inequalities is a really important element of what we do, and a key part of the philosophy that we're trying to set out in the strategy is that this is not simply a service that is provided to people who are in need, a reactive service. It should be a proactive approach that thinks about how can we work with the people and communities of Lincolnshire so that they can maintain a good quality of life and a good level of well-being, because the ideal is that people never need adult social care at all. You know, the ideal would be that I could close down the bulk of the directorate because it wasn't needed, because people were leading a healthy life and able to maintain their independence. And so empowerment is absolutely critical, about people living independently and confidently, fostering collaboration so that people can remain in their communities. And just to give a very brief example of that, I've mentioned this to a couple of people in the past, so apologies if I'm repeating myself. In a previous authority, I had a Meals on Wheels service that was not particularly good. Rather than recommission a Meals on Wheels service, we in fact reviewed each of the individuals who was receiving that service, and we worked out a community alternative for every single person, so that there were local food outlets that would walk the food to the individual. There were luncheon groups that would be available to the individual, and volunteer drivers that would take people. The community pulled together and we were able for every single person to get them a community solution rather than a formal care solution. And that was not only better for the community, because actually it was getting the money that people were spending into local shops and the like, but it also meant that people weren't having to pay for a care service, because of course we always have to remember that adult social care is a means-tested service, and therefore if we are pulling people into the service more than they need to be, we are taking money off them to pay for care that they might not actually need. So collaboration across communities, empowerment is critical. Having access to high quality information, advice and guidance is vital for people to be able to make informed decisions for themselves. Having a strong and diverse care market, so that we're not trying to put individuals as round pegs into square holes and saying, well, the only care that's available is this, it doesn't meet your needs particularly, but you're going to have to go to it because it's the only thing that's available. Absolutely, we need to make sure that there is a range of care available. Championing co-production, an absolutely central principle, and we'll come on to this, I'm sure, more later on, that services and the approach need to be designed with people, that we don't do to people, we don't do for people, we do things with people. There is a lot further we need to go on that, but that principle of co-production. I've talked about a strength-based, person-centred approach, focusing on the individual, what they can do, and therefore what is it that they may need some support to enable them to do more, rather than saying what can't you do, and therefore what do we need to do. And then obviously delivering value for money. The council does not have a bottomless amount of money, and we always have to get the best value for money from that. So I've spent quite a lot of time on that. I'm going to sort of skip through now much more quickly. So the next slide, we have a range of guiding principles about how we will work. The next slide then starts to get us into some of the local demography, because obviously the strategy needs to be a strategy that is based on Lincolnshire. It can't be a cookie cutter strategy that you just cross out the name of the council and put in Lincolnshire. Lincolnshire is unique in its character. We need to make absolutely sure that we are recognising that. The next slide then recognises some of the wider context that we are operating in, which will have an influence on the way that we work. I just draw attention, for example, to the NHS long-term plan. Actually, the 10-year plan has been published since this draft was produced. We know that the NHS is reorganising again, and that the Integrated Care Board for Lincolnshire will disappear and be incorporated into a Derbyshire, Lincolnshire and Nottinghamshire Integrated Care Board. That will change some of the ways in which we work, and we have to reflect that. The next slide then again takes some more about the local context, about the key issues for us. Can we go to the next slide from this one? There we go. Some of the key pressures, some of the key issues. So the demography in Lincolnshire is very different from most of the rest of the country. Our geography is very different from the country. Our health inequalities are quite particular. It's very easy to think of Lincolnshire as being quite a prosperous and a very nice part of the country. You as members will be very aware that in fact we have some areas of very significant deprivation in the county, both in terms of absolute poverty and also people's access to services, particularly down the coast and some of the rural areas. And then the importance of us being aligned to a range of other strategies, the health and wellbeing strategy, the council's corporate plan as that is updated, and the integrated care partnership strategy. So lots of things we have to be conscious of where we're working. Clearly, moving on then to the next slide, there are a number of things that we do well. I've talked earlier about the CQC pilot assessment. Although that has been now struck from the record as not having longer term standing, it's still true to say that there are only 2 councils in the country that have come out with a better grading than Lincolnshire did when we went through that process. I should caveat that although CQC is nearing the end of that process, they've so far only issued 50 out of the 153 reports. So it's currently still a relatively small sample, but there are only 2 councils in the country that have come out better than us. So there are many strong things. And if we go on to the next slide, just some examples of quotes from people about their experience of working with the services. So I think it's important the strategy is clear about some of the things that we are good at. However, there are challenges. If we move on to the next slide, we are in some ways quite traditional, and in that context, I'm going to say that traditional is possibly a euphemism for old-fashioned. Tradition can be a very good thing, but sometimes less so. We are one of the we stand out from our statistical neighbours in terms of how often we use residential care compared to helping people to stay in the community. We are in some ways not as advanced as we could and should be in terms of our use of innovation and technology. And Derek, sat behind me, has been doing some really useful work in terms of promoting assistive technology and innovation. But we started from being further back than we should be. We have some gaps in the way that we do our commissioning. Worth noting in that regard that as well as Hayley Eccles starting as my as a senior officer within the council on Monday, we also had a new interim head of commissioning start in my service, someone called Michelle Brown, to bring us some strength to the commissioning. We have a very, very strong procurement service. They are second to none in their ability to run a efficient and effective procurement process to get a really good price and manage that contract extremely well. Very, very strong service. We've had a weakness even in terms of our commissioning. So the risk is that we are extremely good at buying what may not necessarily be the best thing to buy. So the risk of hitting the target and missing the point. We have high and growing demand for support, particularly in working age mental health. Financial pressures, the budget for adult social care is forecast to grow by about £20 million a year. So that's just under 10% of the budget. That £20 million is broadly equivalent to a 5% rise in council tax. And so therefore, in effect, if the council were to increase council tax by the full 5% every year, adult social care would take every penny of that. And all other services would be dependent on what was available through other grants and business rates. And then we, of course, have an ageing population, so lots of challenges. So a real need for a strategy. So I've talked briefly, if we go to the next slide, about financial resources. The vast majority of what the Directorate spends is on individual packages of care, and therefore our focus has to be on not only getting good value for money in terms of getting good prices, and we pay some of the lowest prices in the country for our care. That has some consequences, but we need to therefore make sure that we are only providing the care that Lincolnshire people really need, and the way to deal with that is not to ration the care, but to work with the people of Lincolnshire so they don't need the care. So if we move on then, there's a range of information in the slides, which I won't go into, which set some context as to how Lincolnshire stacks up compared to other local authorities. If we go forward then a couple more slides, the reach and impact slide, that just gives you some sense of the numbers that we are supporting. You'll see that approximately a third of the people we look after that we support are working age adults, 2/3 are older people. It's still a very, very small proportion of the population. The key point is that the spend is roughly equal. So on average, a working age adult will cost twice as much as an older person, and they tend to be in our system for a lot longer. There's then a slide about growth in demand to just provide some context there. Again, I won't dwell on that. Next then I'll come to the target operating model, the next slide. This is a central part of the strategy because this sets out our basic philosophy of how to work with the people of Lincolnshire, and the central part of this is a focus on prevention. That the whole emphasis in the strategy is about creating the conditions in Lincolnshire so that people are able to lead a healthier life and maintain their independence. Where people are struggling with that, to ensure that information, advice and guidance and some initial services are available so that with the modicum of support people are able to maintain independence and only draw people into formal care services if they really need them and there are no alternatives, and that really is the best thing. And the comment I'll sort of bring out here is no one grows up saying I'm really looking forward to being in a care home when I'm older, and our goal is to create the conditions across the county so that people don't need to go into a care home. Clearly, if people do need to go into care home, we can arrange that. But the basic philosophy of we do everything we can so that the need doesn't arise. So again, moving through fairly quickly, the next slide then sets out a range of commitments about these are things that areas we need to focus on in order to make all of that happen. So just picking up Councillor Young's comment you made, so the transitions to adulthood, we'll be changing that wording because as I say I don't like the word transitions, but that's one of the areas we need to look at. Hospital discharge is absolutely critical. We need to ensure that we don't. People often are quite sick when they leave hospital. They often get better after they've left hospital. The risk is that we assess people at the point where they leave hospital and think, oh gosh, they've got lots of needs, we'll put them in residential care, whereas in fact a process of reablement and support would allow them to recover significantly so that they would quite possibly be able to continue to live in their own home and not need residential care, have greater independence and not be paying for it. And there's all of those items that I've listed there are key elements of how that will work. Really what the bulk of the rest of the presentation does then is to go through each of those areas. So I'm not going to go through them individually. There are 14 of them. They are there, and I'd be very happy to talk those through as questions later on. So if I just take us to page 86 of the pack, which is about 14 or 15 slides further on, Tom. So I'm making your life quite difficult here, but it's the quality assurance framework. Again, one of the areas that is not as strong as it needs to be is, and links to the issue of variation between teams, is our quality assurance process of ensuring that whereas we already have a very effective contract assurance process whereby we go out to providers, that's the right side, thank you Tom, we go out to providers to check that they are delivering care to a good and consistent standard, working with the Care Quality Commission. Our internal processes for monitoring the quality of professional practice, social workers and occupational therapists, that is not as developed as it needs to be, and that is therefore a key part of the programme. There's then several slides about how we're overseeing the process, and again I won't go into those. And then there's a slide on page 89. So we go forward 3 more slides about implementation. A strategy is merely a piece of paper. It doesn't change anything in and of itself, and therefore it will be supported by a rigorous implementation plan. So I have an adults improvement, an adult care improvement plan programme rather, which is driving forward improvements across the whole of the directorate, and there are a range of aspects set out here in terms of how we will do that. And really, that's probably all that I need to say at this stage. And I'm aware I've probably talked a little bit longer than I had intended, but hopefully that's given you an overview. The last thing I'll say is just as you've said, Chair, this is a draft, and while it is fairly far advanced, and we are on schedule at the moment to take it to the executive on the 2nd of September, it is more important that it is the right strategy than that it is done quickly. So I would very, very much welcome comments from members of the committee for ways that we can make it better. The document that goes to the executive will be a bit different because there are it's still a work in progress. So comments from the committee would be extremely welcome, whether today or over the next few weeks. If the scale of comments from the committee is such that we need to do a major redraft and bring it back here, I'm completely open to that, and really we just want to take the mood of the committee. So, thank you, Chair.
Thank you, Martin. We move to questions from members of the committee. Please indicate to the Vice Chair or myself if you wish to speak. I do believe we've got a couple of speakers. Councillor Bean, please.
Thank you, Chair. Yes, reading through the document, I see in part 13, Equality, Diversity and Inclusion, there's mention of a council's corporate diversity steering group. I'd like to know what this is all about, what its purpose is overall, and how much this costs us.
Thank you, Councillor Bean. I've noticed it's on the agenda as well, and I shall get the Chief Executive to look into this and see its roles and responsibilities, and we'll get back to you. Thank you.
Thank you, Chair.
Councillor Reeve.
Thank you, Chair. Just a couple of points, both around the same aspect, actually. How does the strategy address the recruitment and retention challenges within the care sector, particularly in rural and coastal areas of Lincolnshire? And within that as well, are we relying too much on the private sector, and because you've got to pay profits to private sector companies, is that costing us far more than we should if we had our own staff? Thank you.
Thank you. Martin.
So the strategy is primarily around what the council does. One element of that is about how we manage the market, and we have a statutory duty. The Care Act puts the duty on the council corporately and on me as the statutory director of adult social services to manage and shape the market. So that is one of the things that we have been doing, and we're looking to do more. Recruitment is clearly a significant issue and is becoming increasingly more significant. Adult social care in terms of provision is essentially a national living wage sector. To a very large extent, that has been driven by councils because we can't afford to pay more than living wage. In fact, the costing model that the council uses assumes that most staff are on national living wage, and that's part of the reason why the budget grows much faster than inflation, because governments over a number of years have been increasing the national living wage significantly faster than inflation. So there are real issues with a living wage sector. It means that any other job will pay at least as much as a job in adult social care. And often the terms and conditions of that work will be better than employers are able to offer. The career prospects will be better. And I think we often underestimate just the sheer level of accountability that social care workers have. If you are a care assistant on minimum wage going into someone's home to provide care for them, actually you are on your own dealing with an individual and having to understand and spot is something going on with that individual, and if something, if there is an issue, then working out what needs to be done. So it's an incredibly responsible job. It makes an enormous difference to people, but it is paid at national living wage, and we often find senior care workers will get 50p an hour more. So there are major issues linked to that. The changing demography of the county means that there are fewer working age adults compared to the number of people who are requiring care. So we are working very closely with our providers. We have a very good relationship with providers. The Lincolnshire Care Association, Linca, is a very, very effective organisation. We have very good relationships with them, and we work through the ways to address this. And that's partly through how we set the fee rates. It's partly through things that we can do to sponsor and support training and apprenticeships and the like through the workforce, and then also looking at the extent to which we can bring forward technology so that care providers can rely on technology rather than people, because technology is generally cheaper than people. Specifically, your issue about whether the council should be a provider of services directly. So the trend nationally over the last 15 years or so has been for councils to withdraw from provision. And in fact, Lincolnshire is not untypical in that we in fact have no in-house direct provision at all that is registered with the Care Quality Commission. Generally, it is significantly more expensive for councils to provide that service in-house. I think it's so. The first issue is very few care providers make much money. There was a point a year or two ago where all four of the biggest national providers of residential care were all up for sale, because their owners were struggling to make those organisations profitable. I think it is probably fair to say that quite a few providers, the owners of those organisations, who often are operators, the managers as well, are barely drawing a salary. So a lot of people are not making any money out of social care. As I say, the majority of the workforce is paid at national living wage, and their pensions entitlements are the minimum pension entitlement that is statutory. Those are significantly less good terms of employment than are involved with council staff. The only council in the region that is a significant in-house provider is Derbyshire. They have about 4,500 staff in the council providing services. They have a major programme of divestment, because they're finding that service is costing them much more than they can afford. It is much cheaper in the private sector. What I would say is, although there isn't a direct relationship between the amount of money that is spent on a service and the quality of that service, there is a relationship. As I say, Lincolnshire pays some of the lowest fee rates in the country. We also have some of the lowest average CQC inspection ratings. As I say, there is not a direct relationship between those two, but there is a relationship.
Thank you very much.
Thank you, Martin. Thank you, Councillor Reeves. Councillor Robinson.
Thank you, Chairman, and thank you, Martin, for that report. I just wanted to highlight the technology in this strategy. Promoting the use of smart home devices, I think, is key to developing people's independence. And I think the only real large barrier is setting it up in that initial setup. But after that, it is really efficient in the way of helping people by simply asking Google to turn on a light and giving people back their independence. Just in relation to AI, in yesterday's scrutiny, I actually mentioned the use of AI models to increase efficiency, and I'm glad to see it here. Can you delve into how you intend to use AI specifically to help social workers and their work, and how they might present cost savings in the long term? Thank you.
So very happy to pick up both of those points. So I'll start with assistive technology. I think assistive technology has the potential to be a game changer. That there are so many things now that fairly straightforward consumer electronics can do that simply weren't possible a few years ago. And indeed, I not that long ago, I remember having a conversation with an organisation working with another council elsewhere in the country, and they were making the point that the assistive technology market develops at such a rate that roughly every 6 weeks there'll be a new development of something that is available, something that can be done that wasn't possible 6 weeks before. So it's a very, very fast-moving environment. I think it has become clear, and I think it's one of those things that's sort of quite obvious in retrospect, that social workers and occupational therapists are not experts in assistive technology. They are incredible experts in the process of social work and understanding people's needs and understanding how they can be addressed, but they are not experts in the technology themselves. And I know the comment often gets made of, well, we're all used to using our smartphones and doing our online banking and our online shopping and all of that. So why can't we do it with people who we are working with in terms of them drawing on care? But I would say it's a very different thing for me to do online shopping on my phone and to work with somebody else to work out what their needs are and to work out what assistive technology might be useful for them. It's an order of magnitude greater in terms of the skill that is required. So we've been piloting work in that area. It's been really promising that we've been able to bring in some expertise where we've been able to effectively do the classic social work assessment with someone. We've then been able to draw in the technology expert and say, okay, well, if this is the need and this is what traditionally would be recommended in terms of care package, how could technology help with that? And we're finding that even at the relatively small scale and with a conservative, prudent, cautious, whatever adjective you want to use, methodology for calculating the saving, we are working out that roughly for every pound that is spent in that service, we're saving £1.50, £2. So it's a roughly double saving. I am confident that at scale we should be able to do significantly better than that, and other authorities have. So there's a lot that we can do. One of the key things is, because, as I said earlier, a lot of this is consumer electronics. A lot of this can be bought by people for themselves, and you don't need the council to be involved. And so there's a lot of potential that we're looking at to see whether we could signpost people rather than it being the council doing something to someone, whether someone can do it for themselves. So a lot of potential. We've made some early steps, but there is a lot more to do. Turning then, trying to be a bit briefer, to your question about AI, we are aware that there are a number of authorities in the country that have used AI in terms of social work notes, and that increasingly the AI is able, if a social worker speaks with someone doing their assessment and records it on their laptop, that the AI can then take the recording and fill in the form. And so instead of the position where you have the social worker behind the screen, looking at the screen, focusing on the system and not really engaging with the individual, you can have the social worker or the occupational therapist engage with the individual, and the AI deals with that. The initial estimates are that kind of approach can save about a day a week for a social worker of filling in the forms. We have to be careful that the AI is, it is still developing. It does make mistakes. There are confidentiality issues, but it is really promising. The other side of it, and I know there's councils have been doing this, is when you're trying to pull together an assessment of someone's situation over a period of time. Reading through a case file can take a long time. In my last authority, we had a particular incident where an individual had over 1,000 entries in their case file. We needed a detailed assessment. I had to get a member of staff who it literally took them a week to read the case file and summarise it. There are some other authorities in the country which are using AI to read case files and to bring out key points which are flagging individuals who might need a review or be at risk. So there is potential. We are moving in that direction now. The new contract that the council has let with an IT partner is specifically designed to enable us to go down that route. So we haven't made the progress yet that we need to, but it is very much on the agenda, and I think there's a huge amount of potential.
Thank you, Martin. Thank you, Councillor Robinson. Councillor Everton.
Thank you. I think the move towards finding better solutions is good, and that was really interesting. But I meant also in terms of how we ask people, how we care, as you said, with rather than for people. I saw the other day, I was in a restaurant, and another table was a young man, clearly with, who's one of our people that we support, and with him was another gentleman who was the carer, clearly nothing in common in the, in the personalities, or unable to have a conversation. Obviously transactional, no problem, but it's not like a friend, who you would have picked. And then the person who we have responsibility for sat down, had a nice meal and a drink and so on. The person we're paying, or who's being paid, ate and drank nothing, and as thin as a rake. And I just felt it's not like we're not replacing what we can do with the community. Sometimes you see groups of people going out, with a number with difficulties, and they talk to each other, and they rustle along, and they have a nice day out. But I couldn't help feeling this was not exactly comfortable either for either of the two. So I think, and presumably that's quite expensive as well, one-to-one there. But there must, so I like the idea of doing more with communities, as you said. My worry is that if some people have a lot of difficulties, and they will still always need significant support from our services. So that are we going to put too much into the, how are we going to get the balance right, the acute and the preventative? Thank you.
Thank you, Martin.
So a lot in your question. I could spend a long time answering it. I'll try to be succinct. So I think there are two things. One is from what you were saying, I was really reminded of a conversation I had with someone a little while ago who drew on services. And I remember her saying, I don't want a befriending service, I want to see my friends. I don't want to access the community, I want to go shopping. And for me, that's where the strength-based approach, the person-centred approach is so vital, that we avoid the risk of of being stuck in we provide a service, we provide a befriending service, we provide a community access service, we provide this, that and the other service, that we are centred on, well, what is the life experience of the individual, and what is the best way for them to have a good experience of life. And I very much work on the philosophy, and this is, and I'm in no way unique, this is the way that adult social care nationally works, that this principle that if we do the right thing in the right way at the right time, that will get the best outcome for the individual. And if you get the best outcome for the individual, that will be the best value for money. Because all too often we're providing services that don't really meet the need. And that, the example you gave may be an example of that. So we're spending quite a lot of money giving people a not very good experience of life. And if people have a not very good experience of life, the odds are that they are going to decline in their health. And as they decline in their health, they'll develop more needs, so we'll have to spend more money on more services that may well still not be giving them a particularly good quality of life. But the risk is that we suck people in and spend a very large amount of money, often their money, because it being a means-tested service, on giving them a pretty poor experience of life. And so therefore the strength-based, person-centred approach is, for me, that philosophy of understanding, well, what is it that the individual wants and needs for their life, and how can we make that happen? And actually that's much more rewarding for the staff involved as well, because I was saying earlier how it's a national living wage economy. People don't go into social care for the money. People, a huge proportion of the people who work in social care have a clear calling to work. You know, they want to work with people. They want to care for people. They express love for the people they provide care to, and I think that love is a word that we need to be using more often, because I think the love that is shown by the workers is often quite extraordinary, and their calling means that they want people to have a good experience of life, and therefore that's what we should be aiming for. So I hope that sort of at least partly answers your question.
Thank you, Martin. Thank you, Councillor Overton. Councillor Cook.
Thank you, Chairman, and thank you, Martin, for the comprehensive report that you provided us. Actually, it was really interesting to hear your views on AI and about how that can further support the Directorate, because actually I think for most of us now, I think everybody actually accesses AI, whether we know it or not, pretty much every day now. So the more integration we can do with the Council, I think is very positive. I've got three questions, actually, Chairman. So the first one is relating to the target operating model, and I guess it's how is this going to practically shift services towards prevention and early intervention, and how are we going to measure the success of that, would be my first question. I don't know if you want to take them one by one. Or
that would probably be easier.
That's fine, yeah, Councillor Cook, it's fine. It's really important to strategy, this is so.
So the target operating model, as I said, is absolutely central to the strategy. So how will it affect the way that staff operate? Well, there'll be two things. One is it will give my senior staff, and through the line management approach, that really clear focus on this. We're not just about providing a service, being reactive and just waiting for people to come to us. That our whole stance in the way that we approach the people of Lincolnshire is a proactive one, working with them. And so the target operating model draws us conceptually and in the whole way that we think about the issues we're dealing with. It draws us forward into earlier stages, upstream in people's lives, so that we're thinking about. So we've got people coming into the service now. Well, what could have been done a year, 2 years ago that would have meant that they didn't need to come into the service now? Because yes, that might be too late for those individuals, but there are other individuals who are at that stage now who, if we don't do something, will come into the service in a year or two's time. So it's focusing on that, and it will be causing the practitioners, the professional practitioners at the front line, to be again thinking more proactively. So to give a quick example, so we're very good at doing annual reviews. So the Care Act says that everyone who's in formal care should be reviewed on an annual basis, and Lincolnshire does very well. A lot of places are very, very behind in their reviews. Lincolnshire does very well. However, what has become clear is that all too often the staff have been focused on ticking off that they've done the review, and they'll do the review and say, does this care package meet the person's needs now? Yes, tick, done, review, okay. The target operating model will push them to say, and do we think that there is anything coming up that might mean that the person's care needs might change over the course of the next year, such that the care package might not meet their needs in 6 months' time? And if we can see something that may well happen over the next 6 months, there is something that we can do now to review and adjust the care package or you know, other related aspects that might enable the individual to avoid a crisis, to help them to maintain their independence, to keep them upstream. So it'll have that practical effect. How will we see the difference? We will see a reduction in the rate of people coming into the more formal services. So we know how many people come into residential care, into home care and other services, and we have trajectories going forward over the next several years for taking account of demography, taking account of the general health of the population. This is what we expect to happen. The impact of the target operating model will be that demand is actually less than what we have forecast, because we forecast to sort of carry on as we are now. So changing will mean that we will see a change, and therefore fewer people should come into residential care, fewer people should come into home care, and we'll be able to measure that difference.
And then I think my second question is obviously around, so obviously with strategies, the best thing is to have everybody buy into them in terms of it being sort of co-owned by everyone. And I think in terms of this strategy, so in terms of service users, carers, community stakeholders, what sort of mechanisms are in place to make sure that they are still sort of part of that ongoing sort of co-production of the strategy in terms of making it a success?
Not as much as needs to be. So I'll be very clear that there is a lot of engagement that happens. There is not as much of it as there should be, and it is not as coordinated and structured and systematized as it needs to be. So one of the things that I've asked Hayley as she's come in is to take a real focus on this, and because the principal social worker is one of her direct reports, and he leads on this area, and I've tasked her with bringing together there's a lot there, but it's quite disparate, and as I say, it's not consistent. I've tasked her with bringing that together, deepening it, strengthening it, and pushing forward. And that's also part of the reason why we've restructured to create her division, so that all of the social workers and the OTs are in her division. So we're getting a very clear single message through, rather than different services being in different divisions and getting different messages. So a significant attempt, a significant focus on consistency and pushing through into depth.
No, thank you. That's really encouraging, actually, because I think it's important to all of us. If you're going to have a strategy, we all want it to succeed, and by having everybody be a part of it will obviously help it along its way. My final question, Mr. Chairman, is obviously we know we've got significant financial pressures, and I guess how is it that we as a council can prioritise and fund the transformational goals within the strategy without it affecting the end user ultimately? Because I know obviously we've got a lot of pressure in adult social care.
So inevitably there is a degree of double running. However, as I said earlier, the vast majority of what we spend is on individual care packages. So a degree of double running in terms of staffing and management is quite a small proportion of the overall budget. I mean, to be clear, it's something like £5 of every 6 that is spent by the Directorate is spent on individual packages of care. The amount of double running in overall terms is quite limited, and it's also clear that there are some areas where actually we should be able to make pretty rapid impact. So picking up the point that was raised earlier about assistive technology, the program, the pilot that's been working on that actually will have, even in the time that it's been running, will have saved more money than that pilot cost. So some things can be even within year or within a year or so we should be able to address that. So I haven't had my arm twisted by finance colleagues, but I'm actually not in a position of asking for additional funds to enable this to happen. It's there will be a bit of a bulge in some aspects of the budget, but actually the potential for us to reduce spend on packages and to do that not by rationing need and rationing provision and leaving unmet need, but by working with people to avoid need, there's sufficient scope there that we should be able to pay for that over the course of the MTFP period, and therefore live within the budget.
Thank you, Martin. Thank you, Councillor Cook. Councillor Bean.
Thank you, Chair. I actually have 3 questions as well. First one is, what plans and procedures have we got in place to help move people out of hospital beds and reintegrate them back into the community?
Should we do it as one by one again? So,
yes.
So we have 2 things there. One is we have a very effective hospital discharge service. So we have social workers based not just in the hospitals within Lincolnshire itself, but in some of the neighbouring hospitals. Something like 40% of hospital activity for Lincolnshire people is in hospitals outside the county. So we have teams based in those hospitals. They work very closely with the NHS staff in those hospitals to identify people who are heading towards discharge and to do effective assessments of them as they're getting ready for discharge. That is absolutely critical because, as I said, people in hospital tend to be quite ill, and therefore it is very easy to make an assessment of someone's needs that is actually quite inaccurate, because you're looking at someone in a hospital bed rather than someone sitting in their armchair at home, and what they can do is very different. So we have a very good service that gets people out of hospital quickly. We have very good relationships with the NHS. We score very well comparatively in terms of the number of people who are still in hospital after they've been due to be discharged. We have very small numbers waiting, and the people who are waiting have generally waited for a very short amount of time, a day or so. So it's a very effective service there. We also have a very effective reablement service. It's delivered on our behalf on contract by a company called Libertas. We are increasingly putting a larger and larger proportion of people discharged from hospital through the reablement service. This provides up to 6 weeks of reablement. We collect the data in terms of people's outcomes, and effectively there is an assessment at the point of someone leaves hospital. How much care do we think they might need? Doing an assessment at the point they leave hospital. We then do another assessment at the point where they've had the reablement. I'm going to get the figures wrong because I'm trying to remember them, but I think it is well over 80% of people who've been through the reablement process end up with a care package which is less than was originally suggested at the point where they left hospital, and a very significant proportion of the people who've gone through reablement then have no need for care at all, and therefore they leave reablement without a care package. They are able to lead an independent life. So we've got it's actually one of the success stories of Lincolnshire. We've got a good hospital discharge service, a good reablement service. Where we are not as good as we need to be is that we are still in a position, like most of the rest of the country, too many people go to hospital when actually, had there been appropriate services available in the community that might have been able to pick them up and support them and then get them back home without them ever going anywhere near hospital. Hospitals are fantastic places when you need the kind of intensive care that a hospital is the only place can give. Hospitals are dreadful places if you don't have that need, and actually you have a lower level of need. So we need to do more in terms of making it possible for people to where they've had a crisis, to be supported outside of hospital and then return home. But we're very good at where they have had a crisis and they've gone to hospital to get them home.
So basically prevention is better than cure. Second question is basically about carers, because I see carers as the unsung heroes of the adult care system, because they 99 times out of 100 know the individual that's receiving the care, and they can provide better, much more personalised care than we ever can. And so what I really want to know is, what procedures have we got in place to support these carers, because it's far more cost effective to support a carer than it is to care for someone directly.
So you are absolutely right to emphasise the role of carers. I believe there are something like 70,000 carers in Lincolnshire, but it's near enough 1 in 10 of the population. Without the care that those individuals give to family members, to loved ones, to neighbours, our society could not function. It is a absolutely critical role, and we are very conscious that the time and commitment and energy that carers give is often at significant cost to themselves. The impact on their lives can be really significant. So we have a carer service. Derek sat behind me in terms of public health, has played a leading role in developing and establishing that carer service. We provide significant support to a range of carers. The Care Act gives carers a statutory entitlement to an assessment of their needs, in addition to the needs of the individual who's cared for. There is always more that we could do, and as part of the prevention focus, one of the things we're looking at is, well, what additional could we do? What would be appropriate? Very much trying to avoid falling into well, we need to provide a service for people, but seeing what support might be available for people, and that might be about bringing together networks, bringing in communities, ensuring that employers are more understanding about the burdens of being a carer and can be more supportive there, or that businesses provide opportunities and discounts for care. A whole range of things. And one of the things that we've done within the council itself, because a significant proportion of council staff are carers, so we have a staff carer network, and we've been actively supporting them so that we are being a good employer as well as supporting carers across the county as a whole.
Thank you, Mr. Chair. And my final question is regarding the co-production model. I have some concerns with co-production because we're dealing with outside bodies and we're also dealing with individuals and members of the public. So what I really want to know is what sort of vetting procedures have we got in place? Because as an organisation, we have safeguarding responsibilities because we're putting people in contact with vulnerable adults, and we need to make sure that we're not leaving them open to being abused or to be exploited. And I think, we've got to learn lessons from the past, and so the only name I will mention is Jimmy Savile, which is a classic example of where this kind of model can go horribly wrong.
Indeed. So safeguarding is you're right, absolutely essential to this. So, of course, all of the practitioners within the directorate are DBS checked, and we are, we're very careful with that, and there are all of the procedures, all of the safeguarding procedures that you would expect, and of course that applies, to me as well. I'm DBS checked. Where we draw in external organisations, part of the contractual arrangement will be that, of course, they are also DBS checked, so that we can be confident. Now, I recognise, of course, had there been a DBS check of Jimmy Savile, it wouldn't have come up with anything. So we recognise the importance of having really effective routes by which, if anyone does have any concerns, that there are easy ways for people to report those concerns and for those to be correlated and triangulated and taken forward. So there's always more that could be done, but I would give you an assurance that we have robust and effective arrangements in place. But we're always looking at them, and if there are suggestions for how we can improve them, I would be very happy to receive those.
Thank you very much, Chair.
Thank you, Martin. Thank you, Councillor Bean. Councillor Woolley.
Thank you, Chairman. A number of questions here, so it might be easier if I just walk myself through them. Martin, you said right at the very beginning, you've been here 2 years now, seems like 5 minutes, but you referenced variation. So are you hoping to get this variation ironed out within the life cycle of this strategy, or is it going to be before then?
Absolutely. If we haven't got it sorted out within 3 years, then we've got a major problem. I mean, it will be an ongoing process, but I would be expecting to see progress during the course of this financial year, and significant difference by next year. So it's a matter of months as opposed to a matter of years.
Thank you. Callum touched on it around the knowing how we get to people earlier. And within the document, I couldn't see almost, it's all right those that we know or those that we might be getting to know, but how do we get to the people who give them the right information and they don't even get into the preventative arena in the first place? So there's a bit of a gap for me. In other words, it's public knowledge. How do we give people the confidence of going, I need to do X, Y, and Z for myself?
So you're absolutely right that it's that issue of reaching people that we're not reaching directly, and in many ways we don't want to reach people directly, but we want them to be able to access information readily. So there are things, the Connector Support website that we have, and a range of other areas. We are increasingly talking with the voluntary sector about how we can inform them so that when they have engagement with people, and I think this falls very much into Derek's areas as the Director of Public Health, of the sort of the health promotion, the engagement with the wider population, both so that we are getting messages out there that members of the public will pick up, but also that we really understand the nature of our population, so that we can identify areas and groups and cohorts where a particular focus might be required. I'm not sure, Derek, do you want to come in on that, how we spot people?
Thanks, Martin. I was going to mention the Connector Support website and expansion of that approach, so that people who aren't yet known to services and probably don't need services are aware of a single point to look to, which could pick up some of the technology-enabled prevention and care devices, maybe with a trusted provider from that side that doesn't connect into the council at all, but people have that sort of quality assurance process. Is certainly something we're looking at. I think the other thing that comes out in the 10-year health plan is, and it builds on the AI question, is predictive analytics. So there's a lot of work that we've already done in Lincolnshire, and we're quite a long way ahead of most places to connect up lots of different data sources, which over time, and as AI becomes more used, will allow us to predict, based on the characteristics of individuals and places and families, people who might need some proactive signposting, but that will then avoid care interventions. And the timescales for this look like they're going to be accelerated, which is really good news, because it will give us an ability within a finite resource, whether it's the money that we've got or the people that we've got, we'll be able to target better into those areas and those families' advice and guidance, which is part of Martin's statutory responsibility as the DAS, but we'll be targeting it and helping those individuals and families to look after themselves better for longer, and either stopping or delaying the need for further care from the council, or indeed the NHS.
So we'll be looking forward to 99% personal budgets then, will we, by the end of the year? I'll wait for an answer on that one. So the next one that I want to touch on, again, it's to do with the document. I appreciate, as you said, the document was written before the 10-year plan came out. However, as we now know, ICPs are gone with the wind, and although I think the wording is that they'll not, my words, that not the government's, but they'll wither on the vine. They won't. I don't think they're going to give a definitive right. That's the end of them. But I do just wonder whether if this document's going to be meant to last for 3 years, that why not update it now? We know what's come out, so why not make that suggestion? Because I think that it starts it off as a fresh live document, rather than next year having to update it. If it is only for that, it might be for other things.
Yes.
And likewise,
yes would be my answer to that.
Likewise, with the slide where you mentioned the CQC, you've said that they've already struck off their website our grading from last time round. So I do wonder whether you ought to take out that comment that says positive CQC assurance outcomes. I think that's pushing it a bit, because if somebody went to look for them, they wouldn't find them on a CQC site. And then I suppose the biggie for me, and it is the last question, Chairman, you'll be relieved to know. Well, it might be the second to last. First of all, co-production, I was going to just flush out that, how do we just make sure we're not getting the same the same people giving their views on things? Are we getting as broad as possible? And again, really easy with people that are already in our system, but what we actually need to know is those that are not in our system. This is the final question. You have mentioned, quite rightly, that we enjoy an absolutely super working relationship with NHS Lincolnshire. And quite frankly, it doesn't matter whether it's prevention or whether it's our longer term frail elderly people. If we did not have that relationship, we wouldn't, either of us, be able to provide the services in such a large county that we do. We know that obviously they are moving into, from a regional point of view, into the East Midlands region. Lincolnshire, Greater Lincolnshire, it bothers me slightly that, well, is all of that going to come into the East Midlands region? And that bit probably doesn't matter too much, but it's the continuation of good quality services that, on the one hand, the government is saying, we want coterminosity if at all possible. Well, great, we've got it, haven't we? We've proved that point in spades in Lincolnshire. But then combined authority, is that going that way? Are we going that way? Are we going that way? It feels a little bit muddled.
Yes. So the point has been made to DHSC that it is going in one direction in terms of its footprints, and that national government policy, of which of course DHSC is part, is going in a different direction. The NHS, obviously, as you say, the movement from us losing a Lincolnshire ICB to being part of a Derbyshire, Lincolnshire and Nottinghamshire ICB, we've been told that there will be a Lincolnshire presence, but we don't know what that will be. The issue of Lincolnshire or Greater Lincolnshire is being considered, but I wouldn't hold your breath on that one. The NHS is seeking very much, and this again national policy, to shift a lot of the responsibilities for local connection that have been done by ICBs, and before them CCGs, and before them PCTs, and indeed before them PCGs. I think I'm just showing my age there. That they are looking to shift a lot of those responsibilities onto provider trusts. Interesting. We'll have to see how it goes. But as you say, the good relationship between the council and the NHS is fundamental, and we are pursuing that relationship. Making relations with the people that we know are still going to be here, and seeking to find out who will be here in the future, and we'll have to develop the relationship with them.
Thank you, Martin. Derek, would you like to say a few words? Thank you.
It was just to add to Martin's point about, I think the NHS providers in Lincolnshire are going to become even more important than they already are, especially in terms of delivery of adult social care plans. The relationship the Council Woolly already talks about with the Integrated Care Board, we have with those organisations. So I think if you look at the 10-year plan, they talk about integrated health organisations. and the approach to commission for outcomes rather than lots of you will do X number of these things. There's a real opportunity there, because that, from an NHS perspective, is much better if they can shift how they do things to get the right outcomes rather than being told exactly what they have to do in every situation. That plays in again into the neighbourhood health agenda that's coming through as well. So I think there's real opportunities. I think we are well ahead compared to other places in our relationship with the NHS. We'll need to shift really, and I think Martin's already alluded to, and I'll pass back to Martin, around the relationship from a practitioner perspective at that level is going to be really, really important, recognising that I think for the first time in an NHS type policy document, there's a recognition that it won't be one universal standard offer across the country. The offer will need to be tailored to the needs of neighbourhoods. And again, we've been doing a lot of work on that across Lincolnshire over the past 2 or 3 years collectively. So there's lots of good stuff to build on. We're just going to have to carry on, but probably go faster with different partners.
Thank you, Martin. Thank you, Derek. And thank you, Councillor Woolley. We've got Councillor Lee next.
Thank you, Chair. I think I've probably got the most positive approach about this than the rest of the committee. I think it's a really detailed report, and I think it's been very well explained by both of you. I think it's outstanding, absolutely outstanding. I was an NHS nurse for 21 years, and healthcare and social care, as you'll know, they're very closely aligned. So the ethos of a preventative strategy, being person-focused, is absolutely, I cut my professional teeth on that, and I'm absolutely with it. I loved your example about Meals on Wheels, because, you know, if you think about it, if you were the person receiving the care, the social care, what would you rather have? A van dropping off a meal that you warmed up in a microwave that had been prepared God knows how many miles away, or something that had been cooked around the corner? I know which I'd rather have, especially having seen 1 or 2 hospital meals. Equality and diversity. I get frustrated about people raising this, because essentially it's about identifying people's needs and recognising those needs and addressing what you deliver in line with that. And surely you're going to get the best value for LCC's money if you do that. It might not be the cheapest, but in the long term it will deliver the best outcome, so it's the best way of spending it. I don't think E&D is anything sinister at all. I loved your use of the word traditional. I thought it was very polite. I think for me, I would say I welcome a more progressive approach. Your example of the social worker, you've still got the person taking the interview, but AI is doing the notes. I think that's brilliant. As a nurse, I've seen notes where you've got 3 bundles like that come in, and you sit there on a night shift and you think, God, am I ever going to get through these? And you don't, and you still don't find everything. So I think that's brilliant. It's about using new methods and keeping the bits of old methods which actually work and which are positive, because you're always going to need people in a service. So I do think it's an outstanding report. And I just wanted to say, from a personal perspective, I loved your example about the carers loving the person that they look after. I've got a son that has to have a carer. He was very ill 2 years ago, it was yesterday actually. And he's okay now, but he has someone when his wife is at work, and we entrust him to that person. And there's a lot of trust and a lot of faith goes in there. So you've absolutely got to have the right people who you can trust. And I think I would just say about the Jimmy Savile example, I think it's not really relevant, because I can't imagine that Jimmy Savile, he can't have been DBS checked, surely to God, surely. Or if it was, somebody slipped up. But I think we've learnt lessons from then. And I would say, I see my son with a person that cares for him, and I've got absolute faith in that person. He's been around, I think you can tell because he's been around for 2 years. And I think that's how you know when people stick at the job. But this is an absolutely outstanding report, and I welcome it. Thank you.
If I can just quickly pick up one point, and I think you mentioned about diversity. The Care Act requires us to design care around the individual and to be responsive to the unique needs of individuals. And so for me, the strength-based, person-centred approach is fundamentally about understanding people in their difference and their variation, and making sure that we are enabling people to have a good life in terms that they define it rather than the ways that we would necessarily define it, and therefore we have to be sensitive to all sorts of different people, whatever their experience or background might be, and that's very explicit in the Care Act. That's a fundamental statement. That's the basis of adult social care.
Thank you, Martin. Thank you, Councillor Lee. Councillor Robinson.
Thank you, Chairman. Just following on from Councillor Woolley, actually, about getting the information specifically for carers and make sure that they get to the right place. Forgive me if it's already been implemented or been thought of, but has a chatbot been developed specifically for carers to ask questions and for the chatbot to direct them to that advice specifically from the council to ensure that they get into the right place?
So we have a chatbot on the council's website. I think it is, there is potential for it to evolve into something better, but something does exist. But yes, we are looking at that.
Thank you, Councillor Robinson. Thank you, Martin. Councillor Overton, was this a quick question? Because we are conscious of time, that's all.
Other people have asked more than one, but I'll take your point. I always ask quick questions. What I would like is a little bit more information about understanding the future as this council dissolves and the others dissolve. Are you suggesting that it's going to be the providers that do their own commissioning, set to a government set of rules? How is that going to work, do you think? Thank you.
So local government reorganisations should have no impact on the statutory duties of the council. So if this council is replaced by a different arrangement, I'll be vague in that regard. If this council is replaced by some form of unitary authority, that authority will have exactly the same statutory duties as this council does, and I would expect it to be working in the way that this council does. So I wouldn't expect LGR to have any impact on adult social care in the way that it's done. Clearly, if the council, if Lincolnshire County Council splits, then the administration will be different, but the functions and the duties and the responsibilities would be carried on by whatever new organisations took over.
Thank you, Martin. Thank you, Councillor Overton. We now move on to the actions for the committee. To consider the attached report and determine whether the committee supports the recommendations to the executive, which is on page 11 of the report, and also to agree the additional comments that committee has passed on, and they are passed on to the executive councillor in relation to the item. The first question, does the committee support the recommendations to the report? Want me to read it? Okay. Just bear with me. Thank you. Suggested proposal for item 5. I move the committee supports in principle the draft adult care strategy with a caveat of amendments or additional information identified in the debate being reflected, including strengthening workforce planning, clearer detail on how the strategy will address recruitment and retention challenges in the care sector, particularly in the rural and coastal areas, consideration of the sustainability of long-term cost effectiveness of reliance on private sector provision versus exploring potential in-house services, assisted technology and AI integration, further detail of the role and assertive technology and smart home devices in promoting independence, explanation of how artificial intelligence AI will be used to support social work, assessment, streamline casework and potentially reduce administration's burden. Community-based support and strengthen-based approach, emphasize on enhancing personal-centered devices, services, and reflect lived experiences and social connection rather than transactional support models, clarification on how the strategy will be balanced, community inclusion will appropriate levels of ongoing care for those with complex needs. Tom, you just move that up for me. Is it just, I can't move it up. Oh, cheers, thank you. Implementation of the target operation model. Clarification on how Tom will practically shift focus on preventing early interventions. Outline measurable approach and sustainable co-production with service users, carers and stakeholders throughout the life of the strategy. Financial stability and impact. Additional information on how transformational goals will be within the year strategy will be funded with existing resources, ensuring no adverse effects on frontline services of users. Hospital discharge and re-enablement service. Acknowledge the success in reducing delays in hospital discharge and emphasising on continued investment with the services to maintain this performance. And I ask that the comments from the debate, as these were captured by the scrutiny officer, be shared with the executive ahead of the decision on the 2nd of September 2025. I propose we accept those. Do I have a seconder? Thank you. All in favour, please show. I think that's unanimous. Thank you very much. Thank you. And I do thank you for all your comments and questions during that strategy. It's really important. Agenda item 6. Out of area placements in adult social care. This item is found on page 105 and 108 of the agenda pack and follows follow-up questions raised by members of the committee last time. The report will be presented by Martin Samuels, Executive Director of Adult Care and Community Wellbeing. Thank you, Martin.
I'll be a bit briefer this time. So in a previous conversation, there was a question raised about people, Lincolnshire people who are placed by the county council outside of the county. And I gave a commitment that I would go away and look at the data, and here is the report from that. So what we've done is we've done a data trawl. So there are many thousands of people that we provide, we organise care for, and it wouldn't have been cost effective for me to get a member of staff to look at individual cases. So we did a data trawl, and we looked essentially for individuals who had an address outside the county. We've also looked over a period of 15 months, so we haven't just done a snapshot, we've looked back a year and a quarter. Because the case management system Mosaic doesn't have a specific flag to say this person has been placed outside the county, we can't be absolutely sure that we've identified through this process everyone that is placed outside the county. But we're pretty confident that we've got just about everyone. I should be clear, I am not in the slightest concerned that there is a chance that there are people we've placed outside of the county that we've forgotten about. So they may not have been included in the data trawl, but I'm absolutely certain that we know who they are, we know where they are, because on an individual basis, they'll have a social worker, there'll be a contract with their provider, and that contract will be being quality assured. So I know that we catch everyone, but it's whether we've caught them all in the data trawl, because we as I say, we had to look for certain features in their Mosaic data. But anyway, that was the approach that was used. What we've then done is we've split the individuals by age, so working age adults 18 to 64 and older people 65 plus, and we then looked at them in terms of the type of care that they are receiving. Is it residential care or home care? And we've looked at whereabouts in the country they are. And so as the report sets out, we had 192 people as of the 31st of May this year who were placed outside the county. So that's just over 4% of all residential placements and just under 1% of all home care placements. The key thing is that it's very obvious if you look at the table at the top of page 107 of the pack. It's very clear there's a significant difference between working age adults and older people. So only 65 older people are in residential care outside the county. That represents 2.5% of that cohort. Only 6 people over the age of 65 are receiving home care outside the county. That's 0.2% of the cohort. The position very different for working age adults. So 81 people, 11% of the residential cohort is outside the county, and 40 people, 1.4% of the home care cohort is outside the county. The reasons for that are pretty straightforward. That older people generally have more standard needs, and provision for older people tends to be larger. So residential care homes for older people tend to be in the region of sort of 50 to 70 beds, and that they are able to support a wide range of older people with different needs, and so it's pretty straightforward to place people within the county. Working age adults are much more varied. We have far fewer working age adults need residential care. A working age adult might be in care because they have a physical disability, or because they have a learning disability, or because they have a mental health issue. So very, very different nature of need. And therefore the care needs to be quite specialised for that need. And whereas residential homes for older people, as I say, tend to be in the sort of 50 to 70 units, residential care for working age adults tend to be in the number of 6 to 12 people per facility, and therefore there are an awful lot of small residential homes for working age adults, and that's absolutely as it should be. We're trying to give as normal a life for working age adults, and particularly because whereas an older person may be in residential care on average for less than 2 years, a working age adult may be in a placement for 30 years, 40 years, sometimes even more. And so therefore it's not terribly surprising that with that very different nature of market, it is more common for working age adults to be placed outside the county. However, what we then looked at was in terms of where those people were, and of the 146 people who are placed outside the county, 99 of them are in neighbouring counties. And given the size of Lincolnshire, you'll understand that for many people, being placed in Peterborough might well be a lot nearer to their home and their family than being placed in Gainsborough, as an example, though Peterborough would count as outside of county and Gainsborough would be inside county. So there's actually very, very few people who are outside neighbouring areas, and as it says in the report, most are quite close. It is literally a couple of handfuls of people who are scattered across the country, and that normally they'll be out for 2 reasons. Either that an individual working age adult has particular needs that there may only be 1 or 2 providers in the country that can provide that care, or it may be that you could have a situation of an older person who is Lincolnshire born and bred, lived here all their life, needs to go into care, but their family has moved and their family is now living in Gloucestershire, and there's the decision is taken that, well, actually it would make sense for the individual when going into a care home to go to a care home near their family rather than staying in Lincolnshire. But you can see that's pretty uncommon for that to happen. And then we've looked at whether the position has changed over time. So that's the 2 charts at the top of page 108, and essentially there's been a little bit of an increase in the working age population placed out of county, but not very much. So essentially, there's the data. That's the position. I hope that it answers the queries that were being raised.
Thank you, Martin, for the report. We now move on to the questions from the committee members. Could I ask, if you get a question, could you please do it? Thank you. Put it all in one go if you can, to make it run along a bit more smoothly if possible, please. Thank you very much. We've got Councillor Reeve first. Thank you.
Thank you, Chairman. Thank you for the report, Martin. Just a small question. Are you content with the numbers of people that's being placed out of county, or do we have any plans in place to increase the local provisions provided by Lincolnshire County Council to reduce those out of county numbers? Thank you.
Yes and no. I think the position with older people, that's pretty much as I would expect it to be. I think that one of the principles enshrined in the Care Act is that people have choice as to where they go, where their care is provided, and it is entirely appropriate that some people will choose care elsewhere. We have a very vibrant market for older people, and if someone seeks care in Lincolnshire, it is available. The position is a bit different for working age adults. We have been too reactive over a good many years, and one of the things that I'm looking at is for us to be more examining the data in terms of forecasting the nature of demand, the nature of need that working age adults will have, and working with providers to ensure that that care is available in Lincolnshire. We've all too often, I mean, it's not frequent, but it's been too often that we've been in a situation where a working age adult has needed a particular kind of care. It hasn't been available in the county. We've had to place them elsewhere. And then a few months later, there's been somebody else with a similar issue, and again, the care hasn't been available, and we've had to place them out of county, and then another, and the sort of need to say, well, actually, if we know that there are going to be 20 people at any one time that need this kind of care, well, actually, we can work with a provider to provide that care in Lincolnshire, rather than every time saying, oh, no, it's not available in Lincolnshire, we'll go elsewhere. So we do need to be more proactive, and I would expect, therefore, the numbers, particularly of working age adults in residential care placed outside the county, I would expect those numbers to fall over the next several years, but it will take time because developing that kind of capacity isn't a quick issue, but yes, it's very much on the radar.
Thank you.
Thank you, Martin. Thank you, Councillor Reeve. Councillor Lee, please.
Thanks, Chair. I was determined not to be last this time. My question was very similar, Martin, because I know 146 doesn't seem a huge number and 0.9% might not, but it's still 146 people who have probably most of them got families who maybe want to live their lives alongside of each other, and the distance prevents that from happening. So, you know, it might not be big numbers, but there's still people. And my question was, given the ethos within the 10-year NHS plan, the changes about bringing care more into communities, do you think that in time, I know it's not going to happen in 5 minutes, but in time, the provision and the support might build to a degree that these numbers will really come right down? Because it does impact on families. I've seen it in hospitals where people go into homes and husbands can't visit because it's just too far away. And it might be one person, but it's a big deal to them.
So as I say, I agree. I think I would definitely see the working age adult numbers coming down. I think with the older people, it does happen, but it's really quite rare that we can't provide care. We can't find care locally. But as you say, every person is a person. And so we should be doing work to make it so that people are only out of county if they have actively chosen to be out of county for reasons, for good reason, rather than the care isn't available. And so I'd expect there would always be a number of, partly just because of the geography of the county in terms of older people, and indeed with working age adults, but particularly for working age adults, we're not getting it right, and we need to do something about that.
Thank you, Martin. Thank you, Councillor Lee. Councillor Woolley.
Thank you, Chairman. It's a bit of a housekeeping point. I think, Martin, you said that you'd been asked at the previous meeting to bring this paper here. Can we just make sure that the minutes are accurate? Because there's no reference that I can see in the previous minutes. Read this point is not a big deal, but I think this is more for an officer point of view, that we need to be able to correlate where this request came from. Thank you.
So if I can just clarify, it was in a informal conversation after the formal meeting had finished. So it wasn't a formal request from the committee.
Thank you, Councillor Woolley. Thank you, Martin. Is there any more questions? No? Thank you very much. To consider and comment on the position, I suggest to thank the Executive Director for compiling the information on the out-of-ear replacement, and to note the out-of-ear placement overall present a figure below 5% of the residential and nursing home placements, with a high proportion of those placements in adjacent counties. Can I ask for a seconder? Thank you. Could I have a show of hands? Oh, any abstentions? Oh, no, sorry. Can I ask for a vote? All in favour? That's unanimous. Thank you. Agenda item 7, work programme. At each meeting of the committee, this is an opportunity to look at the forward work programme and make suggestions for items for inclusion in the work programme. Kiara, Scrutiny Officer, will present the report. Thank you, Kiara.
Thank you, Chairman. And please accept my apologies for having just rushed to grab a charger. Thank you very much. So this item contains the committee's work programme, which outlines the upcoming items for future meetings and is meant to help members to ensure that scrutiny still remains focused and purposeful. Looking ahead to the next meeting, which is to be held on the 3rd of September 2025, the agenda includes the substance misuse service and links with prisons, which was previously suggested by the committee as an item to be added on the work programme, and that was on the 4th of June 2025. There will be a report on the application of eligibility criteria in adult social care and processes for assessment, which again was suggested by members of this committee on the last meeting on the 4th of June 2025. And finally, a pre-decision scrutiny report will be undertaken on the salt breaks re-procurement, with a decision date on the 7th of October 2025, which will be taken by the executive. Finally, there have been no further changes to the work programme since the publication of the agenda pack, and members are invited to provide any comments or suggest future items for inclusion. Thank you very much.
Thank you, Kiara. Do we have any questions at all? Councillor Woolley. Thank you.
Thank you, Chairman. I wonder if we could, and I don't mind when it is, but if we could have an agenda item on, we've just discussed out-of-county placements, but if we could have a conversation around placements from private, how many private care homes we have in Lincolnshire and how many placements we have coming into Lincolnshire. I think that would be quite useful from a geographical point of view. Thank you.
Thank you. Is that possible?
Thank you very much indeed. Yes, that has been captured.
Thank you, Councillor Woolley. Councillor Reeve.
Thank you. Do we foresee any emerging risks, such as the upcoming CQC report or financial pressures, that could change the forthcoming work commitment to the committee?
I will pass this on to Martin. Thank you.
I mean, I think I would expect to give a verbal update to the committee at each meeting from the next meeting in terms of the CQC. And then when we receive the report and it's published, then we would bring that report to the committee. But I think that might well take us beyond, if it might be on the programme right for the very, very end of the, no, I think we only go up to the 4th of March. We probably won't have had the report by then, so it would appear in next year's programme. The committee will, oh, actually, no, we've got, on the 4th of March, we have got an item about the CQC. We'll have to see where we've got to for that. And then on the 28th of January, there's an item about the budget. And so that will be the usual item for give the opportunity for the committee to go through the adult social care budget in detail and make any comments on that. If there's any issues that are arising in the budget, that will be the point we'll bring it.
Thank you.
Thank you, Martin. Thank you, Councillor Reeve. Councillor Lee, please.
Thanks, Chair. I note that on the 22nd of October, we've got the first item is intermediate care and preparations for winter. I wondered, obviously you'd have to wait till well after winter before you evaluated, you know, if it had worked and everything. I wondered if at some point, and you'd be the best judge of this, we could evaluate how things were going. After X, I don't know if that would be after 6 months or what, you'd know better than me, but just to keep an eye on how things were moving. And it could even be a report for information, whatever.
I would have thought we'd be able to do something for March.
Absolutely. At the meeting where the report will initially be considered, that can be added as a request by this committee, and that will subsequently be added into the work programme. Thank you.
Thank you. Do we have any more questions? No, thank you. I move that the committee's work programme be endorsed as detailed in page 109 to 114, with a caveat of additional items highlighted in today's meeting to be reflected in the next published itineration of this document. Does anyone dissent? If so, please indicate now. Thank you, that is agreed. Thank you. That concludes business for this formal meeting. We can now take the committee opportunity to discuss some of the issues in adult care and the community wellbeing in more detail. Thank you.